want to thank the organizers for an opportunity to put this talk together and present to you. I'm not a molecular geneticist. I'm a clinician who has the opportunity to see a lot of people with myeloproliferative neoplasms. And I am on a steep learning curve, both in regards to the potential and the pitfalls of the new technologies that are rapidly evolving. But I think it all is positive, has the potential for great positivity, so I hope I can put this in perspective over the next 20 minutes. My disclosures have nothing to do with the talk I'll be giving. And just basically I want to answer 4 questions. What are the mutations we're talking about, which is basically a review, and then we'll move on to the others. So the mutations are basically divided into driver mutations, and then non-driver mutations, and the non-driver mutations are quite varied, and they're varied in terms of what effects they have on cell function, from gene expression to RNA splicing, DNA repair, transcription, and so forth. The drivers, you've seen this many times during this symposium, but basically ET and PMF share a relatively complex set of different driving mechanisms, but the main common denominator is they all drive JAK2, STAT5 signaling. Please note that 10% of these are still what we call triple negative under intense investigation. Some erosion into the unknowns this year with a couple of recent studies on MPL mutations and so forth, but this is we think, extremely heterogeneous group. The non-driver mutations are many. These are some of the more common ones. The function on the left-hand side, again, reviews what these various proteins are involved in. The frequencies in PMF, we note, are also seen in CML and MDS, but I'd just like to point out a couple of things. One, there's a few of these that seem to be enriched as patients go into the blastic phase of the disease, and by implication may be causal. And then in the other diseases, we actually, some of the common ones like SRSF2 and ASXL1 are actually even more prevalent, and MDS has a similar share of the, or higher proportion of patients with these various mutations. This is a very nice overview of where we are right now in terms of the molecular understanding of the diseases, published just recently by Dr. Weinchenker, the father of the JAK2 discovery. And basically on the bottom panel, we're dealing with early ET, PV with just driver mutations, but we add epigenetic mutations, and then later on, if we get into the myelofibrosis patients, we add other mutations such that we end up with a more MDS appearance with imbalanced cell production, quite often leukocytosis accompanied by anemia and thrombocytopenia. But this is, I think, the general theme that we're going to see as we understand these diseases in more depth. So what is the risk associated with the mutations? You're all familiar with the IPSS, and it's the one we can apply on repeated patient visits, the DIPSS, which gives extra credit for the development of anemia. But the Mayo group added the karyotype and identified a number of unfavorable karyotypes. Quite often you will find patients don't have karyotypes done, but the facts are that if when these are referred to tertiary centers where the cytogenetics are done on site, and you can use peripheral blood for these very easily, so the fact you can't get an aspirate is not a reason to not be able to generate this. But this is, we're told, is going to be soon antiquated technology, but it's available now. And if one incorporates this into the DIPPS plus, one can generate survival curves like this. And I put the red line down there at the 5-year survival. That seems to be a good discussion point for when you're talking to patients. What is the likelihood I'll be here in 5 years? Now, moving beyond the cytogenetics, DNA sequences certainly has contributed a great deal over the last decade. And the calreticulin driving mutation, I think, is a good example of a disease that's very different. And this is a slide you saw yesterday, and it's just showing that on the green line that the development of anemia, thrombocytopenia, or leukocytosis as a time-dependent variable is much more benign in the calreticulin. This translates out into better prognosis. The other point here is that we have now the triple negative, the ones where we don't know what the driver is, doing the worst in almost every analysis that's been done. The importance of this is if we take the driving mutation and look at say the two extremes, the calreticulin versus the triple negative, and then apply it to low-risk patients or even high-risk patients, you can still sort out within those subgroups higher-risk patients. So you've taken a person, particularly the low-risk patient, who by virtue of being triple negative in the driver mutation category ends up having a higher-risk disease. And this is statistically significant if you compare the CALR versus the triple negative. This also translates out into poor outcomes with transplantation. It's not a reason not to do the transplant because these survival curves are significantly better than they would have been without the transplant, but we still have obstacles to overcome with these higher risk patients. And then to finish up with the driver mutations, it was realized early on that there was a huge variety of these mutations, but if you had an insertion, this wasn't as good a prognostic variant of this mutation as if you had a deletion. And so deletions are called type 1, which preserve the better outcome, and then type 2, which fortunately are less common, seem to be they're less favorable. There's one study that did not confirm this, but this was two different, the Mayo group and the Florence group generated this data. So let's move from driver to somatic mutations. You've also seen this slide before, but basically they looked at 10, used Sanger sequencing to look at 10 different mutations, somatic mutations and driver mutations. This is before we had CALR in over almost 900 patients, 500 from Florence, about 400 from Mayo. And what one sees when they subjected this to univariate and then multivariant analysis, that looking at the risk of developing leukemia or overall survival, 5 of these were identified as having high risk and were called so high mutational risk patients. And if one plots that out and just uses that only as your prognostic score, you can generate overall survival curves by just the mere presence of any one of these 5 different mutations, either one or more. Importantly, that if you apply this to patients already risk stratified by virtue of the IPSS scoring, it also significantly changes that, and that you have a subgroup of patients who, by virtue of having these mutations, will come out as poorer risk. And this on the top is showing the overall survival risk, I should say. On the left is the combining low risk and intermediate 1. On the right is combining low, intermediate 2, and high risk. And on the bottom 2 panels are showing the risk of transformation to leukemia. So this is, I think, this concept is important, that if you know this information and it's important to you, you can alter the risk assessment. If just merely you count up the number of these risk factors, and we've seen this in MDS, so this shouldn't surprise you, but if you count up the number of mutations, it does alter the risk categorization as well. And we see this on the left if we combine all the IPSS risk groups and look at overall survival. And then if we sort out just the low and intermediate risk groups, which we can sort them out into 3 groups: 0 mutations, 1 mutations, and 2 or more. And the 2 or more are the ones that do the worst. Fortunately, in all the IPSS groups, this is just about 7 to 8%, and in the low and intermediate group, this is just 5%. But you pull out 1 in 20 patients who, by virtue of having 2 or more mutations, is destined for a poor prognosis. This is overall survival. This is the same scheme applied to leukemia risk and the same proportion of patients. So, excuse me, 1 in 20 of your patients, for instance, who normally you would have thought as low or intermediate risk, is now identified as having somewhat higher risk or significantly higher risk. This is not the only study that's shown this. Is one of my favorite articles where the Krolowitz group took 200 MPN patients and looked at 100 oncogenes and did the tedious task of ruling out what were variants versus true somatic mutations. And in doing this, they were able to identify and I think advance the field significantly. Included in this were about 35 patients with MF, and they in all the patient groups, predominantly in MF, they were able to show that the number of mutations does matter in terms of both survival and transformation to AML. We'll come back to this in a moment. You've seen this in a couple of presentations today, but Alejandro Banucci has tried to pull together the known risk factors that we had from the previous international prognostic scoring systems, and then incorporate the genetic mutational analysis. And in so doing, some of the factors dropped out. This was univariant and multivariant analysis. And in the multivariant analysis, they were left with these that are listed. They included the age, hemoglobin, and constitutional symptoms, which were from the original, and then platelet counts, and then triple negativity. The driver mutations became important in a negative way. And then ASXL1 and SRSF2 survived. And they were given various weights based on their hazard ratio, and if one uses that to calculate a prognostic score, you can generate this kind of a curve. I don't know what this means, but the Akeki information criteria, I'd like to call this person up and find out which of these scores to believe. But this is an example of a statistical maneuver that tells us that perhaps this is a more reliable score. I just want to point out before we leave this that people before have mentioned TP53. This is where you don't stop to fix things as you're going through G1. If you lose wild type in your clone, you're very likely for a very bad outcome. And I think this is not unique to our diseases, but it's seen across oncology. And so loss of heterozygosity in the presence of mutation leads to rapid transformation, and I think this is important information. And occasionally you'll see this in patients with ET, and not knowing that up front could be a real problem. Applying from these studies, which are all done in primary myelofibrosis patients, to post-ETPV may be problematic. They've tried to do it in the triple negative and the SRSF2, both retain significance. However, the numbers of patients studied, it seems like a lot, but it's relatively small for these types of studies. So let's just finish up, and this is the editorial part. What clinical utility and what are the current limitations? Well, the clinical utility is all based on context, the clinical therapeutic context, and this is at risk of saying the obvious, but what is going to be the impact of the myelofibrosis on your normal life expectancy, and of course the higher the impact, I think the more refined we need the prognostic score to be. So it's very different if you have your 45-year-old gentleman trying to put his kids through college and they end up with an intermediate 1 score, and you're trying to figure out, should he go to transplant now or can I wait for a while? This kind of information would be very valuable, not so much in the 80-year-old person that's just had 2 heart attacks and has comorbidities and is not able to travel to centers for studies and so forth. And then the other thing is what therapies are available, and it's pretty simple. There's not a whole lot of studies, or therapies, I should say, except for experimental therapies and allo transplant. And so for younger patients, we're asking an allo transplant question. For patients not eligible for allo transplant, experimental therapies become very attractive. And in clinical practice, we can take people through JAK inhibition, but I think it's valuable to know what the landscape is of your mutations as you start JAK inhibition if you have a patient that, say, may be eligible for transplant, because if you're starting with 3 mutations at that point, one, they may get a response, but it won't be a major response, and it probably won't last a long time. These patients really deserve to be hooked up fairly early with a transplant center. So I think we'll come back to this moment, but I think we're going to be able to incorporate this sort of thing earlier and earlier in our evaluation of these patients. So I think there's some current limitations. As I see this work at the beginning of the end of the beginning, in other words, we just opened the door and we're getting a little peek, and point out that we don't even know all the driver mutations. And then we also, I think the molecular complexity of these diseases is somewhat humbling, and it's going to require really large ClinPath databases like the folks in Florence and Houston and Rochester have been collecting. I think this is going to be a really important contribution as we go forward. There are economic considerations where at the moment in private practice you have to figure out if you're going to be reimbursed. And I think, as goes with any test, if you're not going to use it, don't abuse it. However, my colleagues that are setting these tests up tell me it won't be too long before we're going to be able to get 50, 100 panel next-gen sequencing done cheaper than doing 3 or 4 PCRs. So I think this is what we can look forward to. And then the other point I'd like to make is that I think we're just really looking at the surface, the hierarchical structure of the malignant clones. I think it's rarely looked at, but I think it's pretty important. We've already heard order of acquisition is already been shown to be an issue. Loss of heterozygosity, if you have a variant frequency less than 50%, you don't know if you've lost heterozygosity in your clone. And then cooperative interactions and multiple mutations within the same cell. That's not really being looked at routinely. And let me just remind you that Darwin used comparative anatomy and fossils to figure out survival of the fittest could explain what occurred over eons. And then we're just compressing this sort of like a time warp, taking it into an individual. Still, it's survival of the fittest as well. But we're only rarely looking at the branches, the trunks and the branches of these, the phylogeny, if you will, of our disease. And I think this is a study, again, the same study where they took patients with multiple mutations and they grew colonies, and then they individually genotyped the colonies and say, let's take the second case down here. And it has, the mouse going to work? Oh, here we are, sorry. Second case down here, if you sampled this colony, it would have 3 mutations in it, whereas this would have 2 and this would only have 1. And by, you can reconstruct the sequential acquisition of mutations that way. If this patient's heading for problems, if you have an EZH2 inhibitor, great, you can plug them into that sort of a trial, but we don't even know if that's, if we have to go after the calreticulin or if it'll be sufficient just to do that. So there's a lot of things that need to be unraveled, but I think we're at a hopeful time. And I think risk assessment certainly enhances our ability to prognosticate. Cytogenetics is already an established form that we could use, but it's going to be soon replaced by the DNA sequencing. We already have identified the non-driver mutations that are significant in addition to the driver mutations, and it's inevitable that there's going to be new mutations uncovered. And I've talked about the context being extremely important. And I think beyond risk assessment, I find this extremely exciting time. This is understanding pathogenesis and the search for rational targetable pathways, and then our promised land of personal therapies, I think, this is a real platform for reality-based hope. So thank you.